All right. Well, we're continuing on with some more clinical conversation. Thank you for doing this. I really
Absolutely.
appreciate it.
Yeah.
So I was thinking of my pet peeves, and another one of them that I thought about was steroids.
Yes.
And what steroid do you like to use?
Depending on the patient, you may use a Medrol dose pack or just a prednisone or sometimes a prednisone taper. Depends on the
Why do
patient.
you pick that? It's just what you've seen over time?
So I mean, depends on, are you trying to treat just general inflammation, or is it somebody who's, COPD type picture, or?
And those are, so when I went back and looked at, because I had the same question, you see people get 125 Solumetrol is common, right?
Yes.
Do you know how many milliequivalents of that is prednisone? The equivalent to 125? I didn't know
do
this.
not off the top of my head, no.
And I may misquote this, we'd have to look it up, but it's
Okay.
something like 240 milligrams of prednisone.
Okay.
Isn't that outstanding? That's a huge amount.
That's a lot. Yeah.
That's a lot. So when I went back and I looked at the literature, what you and I want is the anti-inflammatory function of the steroid, by and large. You know what I mean? Unless you're in a mineral corticoid, whatever, acid, something like that. Yeah. Short of that, asthma, be it, you got somebody with cellulitis, right? Because the IDSA recommends that in cellulitis. The drug of choice really is Decadron.
Right.
And the reason being is it has the greatest anti-inflammatory with the lowest mineral corticoid out of prednisone, Solumetrol, and that one. I don't know other ones. So the other thing I love about Decadron is you can give it any which way, right? So you can drink it, and it's a small, so you just take it out of the IV bottle, and you give it to them, and they drink it. Doesn't taste good, but it does the thing. You can give it a shot, obviously. You can give it IV.
Right.
The other thing I love, and you'll know this already because we talked about antibiotics, is it lasts for 3 days, right?
Right.
And if they're not better in 3 days, they need to come back, right?
Yeah.
So I love it. It's like my go-to for all things because it reduces that inflammation, and then they're back in 3 days when it tapers off. Plus, they're compliant with it, right? You got 100% compliance.
Yes.
Because you can't undo it once it's in you.
Yeah.
As opposed to the other stuff, they stop. My other experience with it is prednisone makes some people hyper.
Right.
About 10%. Some people manic. I haven't seen that with Decadron. Maybe it does happen with Decadron. I'm going to go on a little bit of a soapbox because you made me think of it. Anytime I talk about steroids, I start talking about quinolones. You like quinolones? You're a quinolone guy?
Yeah, we use them. I mean.
So, and I know I'm giving you a hard time, and I appreciate you for letting me give you a hard time.
Of course.
You're probably too young for this, but there was a drug back in the day. It was called Droperidol, and I am trying to get Droperidol back. It's Napsine, it's the trade name. And when you look at the drugs from Thorazine, right? Nobody really uses a lot of Thorazine. Then you got Haldol, Napsine, Reglan, and they go down in terms of sedation effect.
Yeah.
So back in the day, patients would come in, they'd say, I'd like that drug, and I'd say Droperidol. That's the one you want.
Yeah.
And we would give them Droperidol, and you would give 1.25 milligrams or 2.5. And it would sedate the patient enough, and it's what we used as ketamine before ketamine was a thing.
Okay.
You didn't run into airway stuff because it was basically like a slug of Haldol.
Right.
We used it all the time. The study came out, and it was out of, I forgot where, Finland or something like that. And they said, well, if you give Droperidol, you have to get an EKG because you get QT prolongation.
Mm-hmm.
So we used to give 1.25 to 2.5. I mean, I can rarely, when I'd have somebody methed up, maybe 5.
Right.
But the study they did was 125 milligrams to 250 milligrams.
Wow.
And then you had QT prolongation.
Yes.
So I guess if you took 10 milligrams of Haldol and you gave 1,000, you'd probably get QT prolongation out of that. But the interesting thing going back to that is that ironically enough was when Zofran came out. And there was another one called Kytrel back in the day. I think that was the name of it. That was in a similar class to Zofran.
Okay.
And I think the idea was because we used Droperidol as an antiemetic that they did that so then we'd stop using it to make us use Zofran.
Yeah.
So a little bit of history there.
Get you to try to transition.
Yeah. So, but the reason I say that is they gave Droperidol a black box warning. And it got a single black box warning, everybody stopped using it. Because you had to get an EKG, and who wants to get an EKG on somebody methed out? It's not going to happen.
Right.
So, quinolones have 4 black box warnings. Did you know that?
Mm-mm.
4 separate black box warnings. So they have the tendinopathy, right?
Right.
And then they have neurologic symptoms, numbness and paresthesias. They have QT prolongation. And man, I'm blanking on that other one. I will think about it. It'll come to me. But 4 separate black box warnings. So, and the coverage is not very good because of resistance related to it.
Right.
So it's interesting because who would you typically give a quinolone? Who's your quinolone patient if you're thinking about it?
So you've got somebody with like an upper respiratory that you'd like to just give them a medication that they can go home on.
Right, or the other one I see, which is the common one, COPD.
Right.
And ironically, if you look at those black box warnings, the quinolones are most dangerous in the elderly and people on steroids.
Right.
But those very commonly would be, that is the prototypical patient right there that you would hit with quinolones. So I told you I was on my soapbox. I'm a big anti-quinolone kind of guy, just because of that interaction. I'm gonna ask you some other questions. Yeah. Unless you have anything. You got any questions?
No, you're good.
So you have somebody that comes in. Let's do sepsis.
Okay.
Let's do sepsis because sepsis is a hot topic. It's always a hot topic. So how do you? I would say there's 3 classes of patients with sepsis. I'm going to exclude the 18-year-old with flu.
Okay.
Okay, because we can all pretty much recognize that, and we're not going to bark down that path.
Right.
Then one group is going to be the nursing home patient that comes in with a temp of 102 and a blood pressure of 60/40.
Right.
And I think we would both agree that if you can't recognize that as sepsis, you probably shouldn't be doing medicine, right? Then there's going to be the patient who has a bacterial infection, like a cellulitis or something, but it's not big. You're going to discharge them home. And that is technically, you could be septic with that, but you think it's relatively low. You're doing your risk stratification, you think it's relatively low. Then the hard group in sepsis is what I call the cryptic septic people.
Mm-hmm.
So you get your 80-year-old that shows up and they're weak and dizzy, and they come into your triage room. Just off the top of your head, your differential is pretty broad on that patient, right?
Yeah.
It could be a stroke.
Mm-hmm.
It could be heart, right? It could be infection. It could be UTI. It could be pneumonia. Who knows what it could be? It could be any of those. So my approach to sepsis is relatively straightforward. And I hate to say that I dumb down everything, but once you meet my wife, she'll tell you I dumb down everything because that's how she talks to me. So when I see a patient, I think, am I going to admit him or am I going to discharge him?
Right.
I honestly don't care that much about the vitals. I mean, they help me, right? If you get a heart rate of 120 and a blood pressure of 60/40, it kind of slam dunks it for you. But when I see somebody, if I'm going to admit them and they have an infection, I give them an antibiotic and I do the sepsis order set. And that's very simple, right?
Right.
Because I would say, if they have an infection, why aren't you treating the infection, right? Now, your question may be, well, how do you know they have an infection, right? So they come in and they got chest pain and they're 70 years old and they got a cardiac history. Well, if they're coughing, they're probably coughing for a reason, you know what I mean?
Right.
And in that differential is, infection.
And your physical exam too.
And physical exam can help
if you're seeing things.
Yeah. If they say, I'm peeing all the time, there's a chance they got a UTI. And to be honest, I think you and I would agree on this. If you have an 80-year-old, they keep white cells in their urine all the time.
Right.
It doesn't matter what we do. There's going to be white cells in that urine. So that's kind of my simplified approach to sepsis. It's kind of like what we used to do with meningitis. If you think it, then you should do a tap, right?
Right. And
if you're thinking sepsis, then I go down that road. Now, the purist in you may say, I don't like that, right? Because I'd rather be certain there's an infection. And I wouldn't disagree with you. But we're doing government medicine, right? Because that's CMS that's saying that you can't miss sepsis or you're a bad doctor. So that's kind of my 2 cents on so.
You mean in terms of like prescribing before the labs have come back? Is that?
Yeah. So if I saw somebody, they're 80, they're weak and dizzy, I'm looking for a reason for me not to give antibiotics.
Right.
Do you know what I mean? So the common sepsis fallouts, AFib is a common sepsis fallout. Why? Because you have abnormal vital signs to start, so it's going to flag. I had it and I blanked on it now. The any itis that you diagnose falls into sepsis. So pancreatitis, gastritis, ileitis, enteritis, cellulitis, they all fall in. So diabetes, DKA, falls on in sepsis all the time.
Yes.
Why? Because they're abnormal stuff, right? It's all jacked up.
You're hitting the numbers.
You're hitting the numbers.
Yeah.
You know you're going to hit the numbers. When they hit the door and say, I've had DKA and I got DKA, you know they're hitting the numbers. And then all you need is an itis. And I will tell you, where people kill themselves is a couple things. They will put in a differential diagnosis and say it could be pneumonia or UTI, which is reason. They're right. That's not wrong. But as soon as you put that in there, the abstractors view that as sepsis. Even if you don't find it, your differential considered it, and therefore it might be, so you should treat it.
Okay.
The other one is if somebody puts in gastritis or something like that, falls in all the time. So it's one of those things of thinking of those things that are going to get you caught. You know, what's interesting, talking about the core measures, is there's ways to avoid core measures too. So let's say that you have somebody with chest pain and they have a STEMI, and you saw them, you ordered everything, but they didn't do the EKG for an hour. You get the EKG and it shows a STEMI, and you're like, holy cow. So you do everything perfect, they go to the cath lab, everything's fine. If you diagnose STEMI, you fall out because you didn't treat them. You know, you didn't recognize within an hour the guidelines and all that kind of stuff. Yeah. If you diagnose them with ACS, you don't fall out. Same diagnosis, right? It encompasses STEMI, but you don't fall out. Same thing with stroke. So if you have somebody that comes in and they're nausea and vomiting and dizzy, and you're not really worried about a posterior, but you do your stuff and it ends up being a posterior. If you diagnose posterior stroke and there was delay, you fall out. But if you just put weak and dizzy, you don't fall out. So the same thing goes with bronchitis. So if I get somebody, because they track bronchitis and pharyngitis, so if I get somebody and they come in and they're coughing, and I say, hey, I think you got bronchitis, and you're like, okay, well, I'll do a puffer and Decadron. Great, I'm putting bronchitis all over that chart because I want them to see that, because that fits, right?
Right.
If you say, hey, I'm demanding that you give me an antibiotic, and I won't leave without that antibiotic, me personally, I don't diagnose bronchitis. I'll find another diagnosis to put in there. Put in cough, maybe. But something that's not going to flag you to the abstractors.
Right.
So it's kind of like thinking about your chart on the way to be safe or not safe. Same thing with pharyngitis. If you're going to prescribe an antibiotic without a strep test, then don't put pharyngitis. If you're going to do a strep test, put pharyngitis every single time, because you want that to be caught because you did it. Same thing with sinusitis. That's another one. That's a killer too. If you have a sinus infection, you want to do Decadron and go home, I'll put sinusitis all over that chart. If not, and you don't want to, and you demand an antibiotic, then I'll put cough or runny nose, because then you don't fall out.
Okay.
And then
there's definitely another aspect to it that.
It's the business side of medicine.
Yes, exactly.
It's not pretty. I'm not saying it's pretty, but those are the workarounds.
Yeah, and I think that's some of the things that will be helpful to know more about. So thanks for kind of walking me through that.
Yeah. No, I thank you for putting up with me.